And what we'll do is we'll cover kind of, all the sections of the eye and even the orbit. In my medical school, I was frustrated. I didn't really get that much teaching about the eyes. They just kind of avoided it, and I'll treat this lecture like it's 101. I don't know if you've had physiology on the eye or not, but we'll kind of start from scratch and hit the interesting parts of the pathology and the physiology of the eye. So here's a look at the eye. I'm going to hit the basic anatomical features here, and I will switch to full screen for this because I want to be able to draw a little bit. Right up here, I'll start from the front. We have the very clear, transparent cornea. The cornea is the clear dome window that's on the front of the eye that light passes through, and it refracts a lot of the light to the eye. About 2/3 of the refraction to the eye is done through the cornea. Contiguous with the epithelium of the cornea is the conjunctiva. The conjunctiva is a thin layer that makes kind of a saran wrap on the front of the eye, like over the white part, and then wraps around underneath the lids too. Just some squamous epithelium. Deep to the cornea, we have the anterior chamber. The anterior chamber is an important space because it gives us a lot of diagnostic ability for inflammatory diseases. We have the sclera. The sclera is kind of a continuation of the cornea anatomically, made up of essentially the same sort of substance, a lot of type 1 collagen, but rearranged different so that it's not transparent. The sclera is the thick wall of the eye. Deep to the sclera we have pigmented tissue, very highly vascular and pigmented tissue with melanin. It's called the uvea. The uvea has 3 parts. The first is the iris, which is kind of like the shutter controlling the aperture of the light entering the eye. The next is the ciliary body, which is a muscular part of the uvea which controls the flexing of the lens. You can see these little ligamentous zonule fibers holding the lens, controlled by this circular muscle. And then finally, continuing on, we have the choroid, which is a very highly vascular net that is just deep to the retina. In the central portion of the eye is the vitreous gel. It looks transparent. It looks like there's nothing but fluid there, but it's actually a sort of a tenacious jelly with a lot of strands and collagen fibrils. The retina is the innermost tissue layer of the eye, just deep to the choroid, and of course the optic nerve sends all the axons from the retina back to the brain, and then there's the vessels. There's 2 circulations to the retina. There's the central retinal artery and vein, and then actually the choroid provides very much of the circulation to the what we call the outer retina, the back side of the retina. So moving on, we'll go over the orbit. The orbit is the part of the face that holds the eye and the tissues that control the eye. There's a lot of bones in the orbit, and this is a very interesting, if you're into anatomy, this is one of the most interesting places. So many different structures coming together in a very complicated fashion. From a pathologic standpoint, what you are going to see about the orbit is people getting punched in the eye in the emergency room. Or if you're an ENT, you'll know this stuff really well, but I'll draw attention to 2 areas. This is the the floor of the orbit. This is a cut looking towards the nose, above the maxillary sinus. The floor of the nose, the floor of the orbit is, composed of the maxillary bones and the zygomatic and a little bit of the palatine bone. And then the nasal wall of the orbit is also important too, because it's prone to trauma as well. They call this the lamina papyracea because it's paper thin layer. That's a rough translation. Inside the orbit, you have the ocular muscles and the optic nerve originating. All the muscles insert on the annulus of Zinn, controlling the eye movement, the origin of the muscles, and a lot of cranial nerves and the optic nerve pass through this area. The anterior boundary of the orbit is the orbital septum, which is periosteum, a condensation of the periosteum of the bone, creating a fibrous ligament all the way down to the tendon of the levator muscle. The levator palpebrae is the one that pulls your eyelid back. So this little fibrous condensation originating from the periosteum and the tendon of the levator is what protects the orbit from the outside world. So infections on the face, we always call them, is it preseptal or postseptal? Is it in front of the septum or is it behind? The area behind the orbital septum is kind of an immunoprivileged area, and if infections get posterior to the septum, it usually runs wild. So let's see. Anyways, first disease process I'll tell you about is thyroid-related orbitopathy, or you might have heard it called Graves' disease. This is a condition where there's an autoimmune reaction to the thyroid-stimulating hormone receptor, and these antibodies attack the eye muscles. There's some shared antigen causing fibrosis and enlargement of the extraocular muscles. So you get a lot of problems with the eyes bulging out. Over here you can see some of the this muscle on this side, this lateral rectus muscle, is grossly, it's slightly enlarged, but this medial one is severely enlarged. You can see how these muscles are just way too big, and they push the eye out of the socket, getting problems with dryness or double visions or problems with motility. And if they get really large, they can even compress the optic nerve. Here's a coronal section showing these huge muscles. And histologically, you see the infiltration of the white cells into the extraocular muscle tissue, and fibrosis changes. There's a variety of tumors that can originate in the orbit. Board type question: in children, rhabdomyosarcoma is the most common malignancy of the orbit, and neuroblastoma is the most common metastatic tumor to the orbit. Probably worth tucking away. Okay. Inflammatory disease. We talked a little bit about orbital cellulitis. When an infection crosses the septum or originates within the orbit, it's life-threatening. And this CT scan shows this the proptosis of the eye, pushing it forward because of all this inflammatory swelling and damage here versus the normal side, which is dark fat. A terrible case here, a child, the orbital cellulitis can often develop from sinus disease. And then in cases of trauma, we talked a little bit about the blowout fractures. When the eye is pushed backwards, the volume of the orbit cannot contain all the tissues, so the orbit explodes outward. This is called a blowout fracture. In figure C down here, you can see that the orbital floor, that bone we were talking about, part of the maxillary sinus is rupturing open, and then some of the tissues from the orbit, like the orbital fat or the inferior rectus muscle, are becoming entrapped in that bony fracture. What you might see in your ER patient is when you ask them to look up, the affected eye doesn't move up. It's stuck because the tissues are entrapped in that fracture. And we can treat this by putting in a little bony substitute to keep all the tissues up in the orbit to improve the mobility. Moving on to the lids. The lids are a complex piece of skin. There's the, I'll move on to the histo slide to show you exactly what we got going on here. There's skin. There's orbicularis muscle, which allows us to blink. It contracts circumferentially to draw the eyelids close. Back here we have this structure called the tarsal plate, which is very dense collagen tissue, and holocrine glands secreting, waxy substances out of the meibomian gland, which is at the apertures are up at the lid margin. The skin on the back surface of the eyelid here is the conjunctiva. We talked about that a little bit. It wraps all the way around onto the front of the eye. There's a lot of tumors that can happen on the skin in general, and the lids are no exception. Basal cell carcinomas are the most common tumors that happen on the eyelid, and it's usually on the lower eyelid because that's the way the direction of the sun shines. It shines down onto the lower eyelid. That's everyone's theory, at least, but there's a preponderance that happen on the lower lid and not so much the upper. The most common benign tumor is like a chalazion, and your family members will ask you about these every time someone gets one. They're very, very common. Here's a picture of a chalazion. When one of these meibomian glands gets plugged, the contents of that holocrine gland that lies beneath creates a foreign body reaction, and there's inflammation and swelling. So the fatty, waxy contents of that gland start to get giant cell infiltration, and if you did send for a tissue, that's what you would see from a chalazion biopsy. Oh, by the way, you'll see in your books hordeolum also. A chalazion is when it's encapsulated and not so inflamed. A hordeolum is exactly the same thing, but it's more acutely inflamed. The conjunctiva is non-keratinized skin, very thin layer, and it has lots of goblet cells which secrete the mucus for the tears. So I put in this slide to show this is the bulbar conjunctiva. It's on the surface of the eye. It's exactly the same as the palpebral conjunctiva, which is on the underside of the lid. And here's one of these eye jewels. It's a little platinum implant that they do in Los Angeles and the Netherlands. This is really to demonstrate how thin it is. It's kind of like a layer of saran wrap. The subconjunctival implant shows the thickness of the conjunctiva. The most common condition that you'll run into with the conjunctiva is conjunctivitis. So it's an inflammation of the conjunctiva, and an astute clinician can pull the eyelid down and tell you what type. So if you see these large, round kind of nodules that kind of look like domed inflammatory lesions, these are called follicles, and follicles usually come from adenovirus, but they can come from some other things too, but they usually signify viral conjunctivitis. And what these little domed follicles are in the eyes, these are the same things you've seen in the gut, Peyer's patches. They are lymphoid germinal centers that happen just underneath the conj. And when you look at them in the microscope, you can see not histology slides, but you can see the lymphoid germinal centers and, live histology like I was telling you before. There's other types of conjunctivitis, of course. Here's a granulomatous type, a patient of mine that has a baby kitten, a cat scratch fever conjunctivitis. There's some other degenerative conditions that you'll run into. People that live near the equator or spend a lot of time in UV light will get these growths onto the side of their cornea. They look like a wing. Pterygium is Latin, or the origin of the word it means wing. So these wing-shaped actinic tissue growths that show elastotic degeneration under this microscope is called a pterygium. And a pinguicula is the same thing. It just, before it grows onto the cornea, you'll see these all the time. There's a variety of other things that can happen in this area. Here's a look-alike. Someone sent this to me for removal of pterygium, but this is actually a squamous cell cancer caused by HPV. We got this off the eye in time, and the patient did really well. But it looks like a pterygium in some sense. Moving on to the cornea. The cornea is a unique tissue because it's transparent, and it's the most important refractive structure in the eye, meaning that it bends light even more than the lens of the eye. It's about 2/3 of the refractive power of the eye comes from the cornea. It's got 5 layers. The epithelium is a very thin layer of cells on the surface that's richly innervated by cranial nerve 5, and it's exquisitely sensitive. It really hurts if you get an abrasion on the surface of your eye. The stroma is the thickest portion. It's about 90%, and it's very precisely arranged type 1 collagen fibers. The reason why it's clear is because of the way the fibers are arranged with respect to the wavelength of light. There's Descemet's membrane, and I'm going to show you the picture to make it more obvious what I'm talking about. Here we have the epithelium. Here we have the bulky stroma. Descemet's membrane is really just and you can see this, believe it or not, on the microscope, but it's type 4 collagen, a basement membrane for the endothelium. And the endothelium cells, these small monolayer of cuboidal cells, is what actually pumps out the fluid from the stroma and dehydrates it. When the collagen fibrils are approximately a quarter wavelength of light distance spaced apart, then the cornea is clear. If they're not, it's white. Refractive surgery is a hot topic. Here we have a picture of some LASIK being done, showing that the LASIK flap is being lifted on a hinge. A incomplete lamellar cut is made through the cornea, lifting up the flap, and then the excimer laser basically grinds in the precise refractive error, grinds the lens into the stroma of the cornea. And the tissue is ablated to counteract the refractive error of the eye, basically. The flap is put back down, the endothelium pumps out the fluid, and it's adherent again. Here's a retrolumination photo. The light is shining into the eye, and it's coming back to us like a sunset glow, and you can see this accordion appearance of a flap that's been dislodged by a clipboard. It kind of got smushed from the superior direction and has reepithelialized in a bad configuration. This is a gentleman that fell down a ladder well of a submarine holding a clipboard. Keratitis is inflammation of the cornea. There's a lot of different causes, and there's a lot of medical implications of what it might be. It can be an indicator of systemic disease at times. This is herpes keratitis, classic USMLE photo. I think it shows up on every single one, is dendrites, these fluorescein staining areas of viral epithelium damage. Stromal keratitis is another type of HSV keratitis infiltrating the deeper layers of the cornea. And the most common cause of keratitis is people that sleep in their contact lenses with a little bit of Pseudomonas causing an infiltrate in the cornea. I think of infiltrates the same way as you think of an infiltrate on a chest x-ray. You look for an area that's supposed to be clear, like the lung, and you see a white spot there. An infiltrate is a white spot in a clear tissue, as far as chest imaging goes. Same as the cornea. Down here you can see a collection of white blood cells. That's a hypopion. There's a lot of interesting but rare dystrophies that affect the corneas, and I'll show them just for the sake of the pretty pictures. And because you're responsible for knowing about the different types of stains, here's some hyaline deposition within the cornea. Stains well with our patriotic stain, Mason's trichrome, red, white, and blue. Granular dystrophy of the cornea has been described as breadcrumbs on the surface of the eye. I'm sure you'll all recognize the apple green birefringence of amyloid deposition. Amyloid stains with Congo red. That's called lattice dystrophy. Here's a case of ectasia, when the layers of the eye, of the cornea, become deformed because of a structural weakness. Keratoconus is a very common ectatic disorder of the cornea, and it can be a complication of refractive surgery. Here I was telling you about the slit lamp photo. Let me see if I can make sure that this is apparent to everybody. This right here is the beam of light traversing the cornea, and this is the normal corneal thickness. Over here you can see that the cornea gets much thicker, and over here you can see a flap that looks like it's torn. This here is Descemet's membrane, which has ruptured, allowing fluid from the aqueous to get into the stroma of the cornea and cause it to turn white. So you can see the cellular effects of dehydrating the cornea. It keeps it clear. Those single monolayer of endothelial cells on the cornea have a very important job. Corneal transplant, post-op day 1, to correct some of the disorders I've just been telling you about. Uvea comes from, the origin of the word means grape. And the reason why is because the tissue is purple during surgery, and it looks like a grape. As I mentioned before, the uvea is the iris, the ciliary body, and the choroid. So here's the choroid, ciliary body, and the iris. And you'll hear interchangeably uveitis or iritis. Uvea is a very general term, but inflammation in the uvea can happen at any place. It can happen as iritis, choroiditis, you name it. So those are more specific terms for the uvea. The drainage of the fluid in the eye, the aqueous, happens through Schlemm's canal. And this is what controls the pressure of the eye and has implications in the disease of glaucoma, where the pressure is too high. Uveitis is a really interesting, from the medical standpoint, condition, because it is usually a first indication of many systemic diseases. Very often an ophthalmologist can detect and diagnose these diseases earlier than the internist because of the characteristic patterns of uveitis. A lot of autoimmune, inflammatory, neoplastic disorders, infectious diseases, all can show uveitic manifestations. And again, looking at the slit lamp, you can see the individual white cells within the anterior chamber. This is called an anterior chamber reaction, or cells in the anterior chamber. Sometimes those cells kind of fall out on the back surface of the cornea, looking like a little snowbank. Posterior uveitis or choroiditis. This is toxoplasmosis, a very common inflammatory condition of the choroid.
Hello.
Yes, I can hear you.
Hi, we just added Carolyn. She was dropped. So Carolyn, if you're on, just mute your mic.
Welcome back. And then I mentioned that there's a lot of melanocytes in the choroid. And the most common primary tumor of the choroid is the melanoma. Moving on to the lens of the eye. The lens is a very interesting tissue because it's actually an inclusion cyst. Embryologically, the surface neuroectoderm pinches away and forms a cyst, and that becomes the lens. It's an inside-out structure where the epithelial cells are on the inside and the basement membrane is all around on the outside. And what the lens does is helps us fine-tune our focus because it is mobile. The ciliary body can induce shape changes in the lens and help us focus up near. That's called accommodation. Here you can see some of these epithelial cells. The basement membrane is on the surface versus underneath, and all the epithelial cells are arranged in these long, elongated fibers within the center. And it continues to build up that way like a cyst. And the tissue looks like the rings of a tree. When you're doing cataract surgery and removing a lens, you can see these individual layers of the lens. Concentric tissue planes. As these fibers build up and become denser and are subjected to UV light, the crystalline proteins break down and they're not clear anymore. That's called a cataract. Some very interesting forms, beautiful cataract formations, which are all, very visually significant. This one's interesting because you can see the actual individual elongation patterns of some of these cells, kind of like a triple helix or I don't know what you call that. Cataract surgery is a really rewarding operation. What we do is tear that basement membrane capsule open, introduce a ultrasound wand to carve up and break down the epithelial cell fibers and aspirate it out, leaving an empty capsule where we can inject an artificial foldable lens to replace their natural lens. And this is, like I said, it's very rewarding. In 30 minutes, you can make a huge impact on someone's life. You can take a blind eye and make it 20/20. You can take a person who couldn't work or take care of themselves and make them highly functional again. So it's for anyone who's interested, And you can just think about the impact that you personally will have on, your patients. Um, this is where we enjoy our work very much. The retina is my favorite topic because that's my specialty. I'm training in retinal surgery, and the retina is a really complex and interesting organ. It's actually part of the brain. People say that the optic nerve is the second cranial nerve. Well, it's the only one that goes backwards into the brain. I can tell you that. So I don't think it's truly an optic nerve from the way it develops, but it's designated as such. We'll go over some of the pathologic conditions of the retina, but first we'll talk about the anatomy. The photoreceptors are the ones that detect light. The light detection happens, within the visual pigments down in the cones and the rods. And the signal is transduced via the bipolar cells to the ganglion cells. The ganglion cells send their message through axons. These axons go to the optic nerve and back to the brain. Histologically, it's complex. People generally have to memorize the layers of the retina. I think more to understand a complex process. But, the layers are the inner limiting membrane, which is really just a consolidated tissue barrier. The axons is the nerve fiber layer, the ganglion cell layer, the inner plexiform, the inner nuclear layer, which is the bipolar cells, and then the photoreceptor nuclear layer, the outer nuclear layer. Here are the outer segments which contain the visual pigment, and very importantly, I just want to stress this, the anatomic interaction between the retinal pigment epithelium and the photoreceptors. The photoreceptors are extremely metabolically active, and they can't take care of themselves. The retinal pigment epithelium is what allows all this metabolic activity to take place. They nourish the outer receptor, the outer photoreceptor segments, and participate in the metabolism of the visual pigments. The choroid, the sclera. Retinal detachment and macular degeneration are two of the big conditions of the eye that you should be familiar with. Retinal detachment. When the vitreous gel is firmly adherent to the surface of the retina, it can shift and pull a tear in the retina. The tear allows fluid from the vitreous to enter the subretinal space. The subretinal space, I'll show you a picture, is the space in between the photoreceptors and the retinal pigment epithelium. So a retinal detachment does not detach the retinal pigment epithelium, but everything else above it. So when we see these tears, which are usually manifested by flashing lights and new floaters in the eye, we put a spot weld of laser around them so that fluid cannot gain access. We create a adherent scar around the tear to prevent the retinal detachment. As I mentioned, the interaction between the RPE cells and the photoreceptors, that there's no true anatomic junctions between the two layers. And when a retinal detachment occurs, it happens right through this area. Normally, the RPE has a ATPase pump that can pump out all the fluid in this space. But when it's overcome by vitreous traction, then a retinal detachment occurs. Macular degeneration is another common disease of the elderly, manifested by drusen, which are little consolidated clumps of lipofuscin and metabolic waste products at the layer of the RPE and Brooks membrane. There's a lot of vascular diseases that can be seen in the retina. Diabetes is a very common one, and then vascular occlusion events. I think this is another classic board question. You know, what are the pathologic sequence of diabetic vascular disease? You know, number one, thickened and leaky basement membrane. Number two, loss of the pericytes around the vessels, microaneurysm formation, and then finally, non-perfusion and capillary dropout. The ischemia from vascular diseases, this is a very new and up-and-coming topic. It's the basis of many therapies now targeting this VEGF molecule. VEGF is a substance that is produced in response to ischemia from tissues and promotes new blood vessel growth. This new blood vessel growth in the eye is generally pathologic. So here is a fluorescein angiogram. What we do is we inject a fluorescent dye into a person's vein, and then we take black light photos of the eye so we can see where the circulation is containing the dye and where it's leaking and what is perfused and what is not. This is a case of, diabetic retinopathy. You can see that pathologic disease process that we were talking about. You can see the leakiness of the blood vessels. I can't tell you I see the loss of the pericytes, but I can see microaneurysm formation, these very small dots are microaneurysms from diabetes. Finally, you can see, compare, this sort of nice capillary blush to this area, which has absolutely no capillaries, total tissue ischemia. So there's your physiology in action, live histology as I was talking about. And eventually, neovascularization happens. When there's this much ischemia, you will grow new blood vessels and they will be destructive, such as these. Just to orient you, here's the optic nerve, here are the arcades, and here's a big stalk which looks like a palm tree of brand new blood vessels being formed in response to that VEGF from the diabetic ischemia. Vein occlusions and artery occlusions can be directly seen in the eye. They're often an indication of hypercoagulable states or embolic disease from, say, the carotids or cardiac sources, or sometimes inflammatory vasculitic conditions can be diagnosed when these occur. Here's a classic central retinal vein occlusion. They describe this as blood and thunder, and I've seen this picture on many USMLE exams. The fluorescein shows the dilated tortuosity of the retinal veins, and the optic nerve is swollen because of the vascular congestion. Here's some neovascularization of the iris, which will lead to a terrible glaucoma in a person who's had one of these vascular events, neovascular glaucoma. The vessels of the iris are not usually visible. And then, of course, there's tumors. Going back to physiology, with respect to retinoblastoma, this is one of the classic cases of the tumor suppressor genes, Knudson's two-hit hypothesis. This may be familiar, I'm not sure, and I may have spelled Knudsen wrong, but normally we have two genes which protect us from the two genes that help suppress the tumors. when we are born without one of these genes, we only have one gene left to protect us, and any one of those 2 million cells, if they spontaneously mutate their last remaining tuner suppressor gene, it will become a retinoblastoma. The histology of retinoblastoma is classic. You see these Flexner-Winter-Steiner rosettes, kind of 3 layers. Very classic appearance, nice photo. And these tumors are terrible. If they're not taken out immediately, they're extremely destructive and usually fatal. Modern treatment, we have good success in eliminating and curing this disease when it's detected early. And moving on to the optic nerve, we discussed that the optic nerve is a funnel for axons that originate in the ganglion cells. Swelling of the optic nerve, I'll bring your attention to papilledema, is generally an indication of intracranial pressure increases and can often indicate a brain tumor or other disorder. But there's many other conditions that can cause optic nerve swelling, like optic neuritis or strokes to the optic nerve, sometimes giant cell arteritis, inflammatory conditions. Glaucoma is the most common disease of the optic nerve. It's very common. And what we see is high eye pressure causing an eventual destruction of those axons as they exit the eye. So we don't know exactly why the eye pressure causes destruction of the axons, but we know the sequence of events. And when the axons become sufficiently thinned, the area that it subserves develops a visual field defect. So in this little notch right here, I can say that the axons are almost completely gone, and this corresponds to this area of the retina, a big arc right here, and this person will have a corresponding superior visual field loss. So that's the end of the talk, and just a quick summary of some of the important topics that you'll see again. And I can tell you it was a pleasure being able to do this. Thank you very much.
Thank you.
Am I
That was
allowed
great.
to ask? Am I allowed to ask a question?
Yes, yes, you can.
Okay, there were two things that came to my mind when you were talking about this. I've always wondered about. Like one of them was, I know there's like a trick that people play where they take a soda straw and they blow warm, moist air gently onto a sclera and it becomes transparent. Were you aware of this? And if you are, do you have an explanation for that?
Oh yeah, sure. That's easy. I do this during surgery too. If I need to mark the sclera, I just take something and I press on it. And basically it squeezes all the water out of that area of the sclera and dehydrates it, and it becomes clear, kind of like the cornea. Now I would guess that, blowing air on a sclera too could just, dehydrate it and make it clear.
So are you saying that a cornea is very similar to a sclera, except the cornea has less water?
Yes, the cornea also has more precisely arranged collagen bundles. They're almost all in line and uniformly arranged. The sclera is a little bit more crisscrossed. But again, if you reduce the interval of the fibrils to less than a quarter length of a light, then light will transmit through. And now the sclera is not going to be transparent because it's got a purple choroid behind it. So you can't see through the sclera because there's tissues behind it. But it's about the same as the cornea.
Okay, can I ask you one last question I've always wondered about as well, and I've never really gotten a satisfactory answer.
Sure, I'll
Do you know,
try.
do you know where the optic nerves dessicate to form the optic tracts and like Some of them go on the opposite side, and some of the axons stay on the ipsilateral side.
Sure, yeah.
I've heard that division is almost exactly 50% of the axons. Is that correct? And if it is correct, I was always wondered why.
No, it's not. It's not. In the chiasm, the decussation is not usually exactly 50%. And geez, this is something I should remember exactly, but it's more like 52-48. The nasal retina has a few more axons than the temporal, and so that there's an asymmetric decussation at the optic chiasm.
But it's only 1 or 2%, so it's about 50% though, right?
It's about 50, yeah.
Okay, but the nasal has more.
I'm pretty sure, if I remember correctly. Yeah.
I've always wondered if there would be an explanation for why one side should get slightly more. To me, it just doesn't make sense. But if it's 52-48, that's close enough for me.
Yeah.
Okay, I'm done answering my questions. If you look at your Skype box, you can also take questions either by chat or by anybody who wants to unmute their mic. Thank you very much.
Oh, you're welcome.
I have
Thanks,
a
everybody.
question. How
Yeah,
about
sure.
that diabetic test where you get a puff of air to your eye? Is that similar? Is it drying and you can see something different?
Oh, the air puff? No,
Right.
the air puff is not necessarily for diabetes.
Oh,
It can be more for glaucoma. And what that air puff does is it measures the eye pressure. It
okay.
kind of is determining what air pressure does it take to indent the cornea. So that little puff of air indents the cornea, and there's a way that they can measure eye pressure from that.
Okay. Great. Let's see. We have any other questions? Got a lot of thank yous and
Right on.
claps. Okay.
If you can see your Skype box, you can see there are a lot of thank yous, and everybody is very happy that you did this, and I'm, of course, the happiest one of all.
Yeah.
Because you saved me a lot of work.
No, he's proud.
Well, it's a very cool system you got here. It's super interesting the way that this can be done.
By the way, I think we're the first medical school in the country, Little Destiny, to do this technique, not only for our own online students, but we could share it easily with strangers like you who had no idea about it and 10 minutes later are doing it.
Yeah. Yeah.
If there's anything you want to say by last few comments, or if anybody wants to make a last few comments, go ahead. Otherwise, I'm eternally grateful, Johnny. Thank you very much.
Oh, no, my pleasure. You're
Hey,
welcome.
I love you, baby. Bye-bye.
All right, Dad. Bye-bye. Thanks, everybody.
Thanks.
You're welcome.
Okay, they're uncharacteristically quiet today, but